Lisa, who also goes by Elizabeth, is an internal medicine hospitalist and associate professor of medicine at Cooper Medical School of Rowan University. She's also an associate program director of internal medicine and co-chair of physician engagement. She co-chairs the Green Team at Cooper and is a health and public policy and wellness chair for the New Jersey chapter of the American College of Physicians. Lisa is a founding member of the Mid-Atlantic Alliance for Climate and Health. And Lisa, I've been working with Lisa for probably a year at least now, and she's been a great help to me in understanding how health care can be involved as being part of the solution, not just part of the problem of climate change. And as I think Liz Finkelman said earlier, there are some role models or in the country in terms in healthcare, people who are using health systems who are using photovoltaic solar panels for most of their energy needs, who've taken steps on their supply chain, or in terms of creating resiliency in case of flooding or extreme heat events in their communities. And I think Lisa is going to share with us what's going on, especially at Cooper, a little bit more in New Jersey with the hospital association there, that we can learn from here in Delaware, and maybe find ways to partner with them to once again jumpstart our activities and help each other out. So Lisa, you have, I guess, about 55 minutes.
Thank you so much for that wonderful introduction. I really appreciate it. And I have to say that Alan and Pat and Kate have been wonderful to work with through all of this. So some of these multiple roles that I'm fortunate to hold at the health system have really worked synergistically to, I think, build interest in in sustainability and just even the impacts of climate change on health. I think as we've talked so much about wellness and burnout and resiliency in the midst of COVID, healthcare professionals really want to have tools where they can lean in and they can do something positive, because all across the New York Times, public media, you hear all of these kind of doom and gloom stories about the impacts of health and climate change, and we want to be able to impact things in a positive direction. So giving our colleagues, our partners, tools can be very empowering. And so leading into this work has been wonderful for me personally. And I think for a lot of the colleagues that I've worked with, it's really been engaging and synergistic. So I will try to go through the initial slides rather quickly, because a lot of it was covered in detail earlier. So I'll keep the background very brief, and I'll talk about what we've been doing in New Jersey more specifically. The goals and objectives. You can see, healthcare, as you heard, has a very large climate footprint, largely due to the tremendous resources required for clinical care. And so reducing that inefficient, low-value clinical practices can really yield waste and emission reductions and get to climate and clinical sustainability. I do just want to say, out of reverence for history, people, and place, I want to acknowledge that where I am speaking from is the ancestral land of the Lenni Lenape, part of the larger Algonquin tribe, the original inhabitants of this place. I do offer thanks for their stewardship of the unceded occupied land throughout the generations, and acknowledge the thousands of Native Americans who call New Jersey home. So diving into sustainability. So why do we want to focus on this? First, it's a public health crisis. We've seen, and we have talked about earlier in this conference, how extreme weather events can impact both our delivery and access, but also supply chains, how we directly contribute to the climate crisis, and how we can be powerful advocates. And again, how we are called to first do no harm. This is taken from Healthcare Without Harm's website. So again, as we've discussed, we contribute largely to greenhouse gas emissions. And if the US alone was a country, we would actually be ahead of South Korea and the UK in terms of our greenhouse gas emissions. Our emissions have been increasing about 5 to 6% annually. That's some work from Watt and the Lancet Countdown. And if you look at the overall cost, the estimates of cost to convert to zero emissions or around 3% of GDP. And in the US, we spend about 18% of our GDP on medical care, which amounts to about $4.1 trillion. So healthcare is very, very consumptive. And as Dr. Sherman had alluded to, disposability is normalized. So we are already spending money on this. You know, if you look just in 2020, we spent about $265 billion on 3 storms, Maria, Harvey, which ended up dropping about a year worth of water that flows over the Niagara Falls, over Houston, in just a few hours, and Irma, which had the first sustained winds of 185 miles an hour for 27 sustained hours. So we are already paying the money for this. It's just a question of how we want to allocate. This slide was already shown earlier by Dr. Sherman. So again, just to emphasize that our healthcare access in the U.S. is not commensurate with other advanced societies. You can see Japan and France are well above us in terms of healthcare access, and yet we are producing the most greenhouse gas emissions. We far exceed other areas. And as you know, our healthcare delivery is not the best. We have about 10.9% of our population uninsured currently. And while we've been focusing on greenhouse gas emissions, there are certainly other areas, including plastic and antibiotics found in river water. A lot of the resources that we need, there are conflict minerals being scavenged for our medical equipment, thinking about the deforestation as a result of surgical gloves. So we have widespread impacts across our environment. And again, this is some work from Dr. Sherman and Dr. Eckelman. So U.S. healthcare is responsible for about 8.5% of greenhouse gases. About over 25% of the global healthcare footprint is coming from the U.S. And this figure was also cited that that this results in about a loss of 388,000 disability-adjusted life years, commensurate with patient safety events. So this results in a non-virtuous cycle. So you have people who are coming into the healthcare system with health issues, with poor health. We operate on them, we deliver care, we maybe give them anesthesia, medications, and that has an environmental impact. It impacts their local environment, it impacts global environment, and it impacts their health. And then they come back into the health system with more health outcomes. And so you can see how this plays out in this non-virtuous cycle. So when we're looking at greenhouse gas emissions, Scope 1 and Scope 2, as was previously alluded to, are really the minority, about 20% of a facility's greenhouse gas emissions. So Scope 1 is going to be those direct emissions that are coming from the facility: heating, cooling, cooking, the company vehicles, anesthetics falls in here. Your indirect is going to be purchased electricity, and then Scope 3 is really everything else. So I have some of them written out here, but it can be travel, it can be research, investments, a lot of the pharmaceuticals and the medical equipment. And because Scope 3 does encompass so much, it does result in about 80% overall of the emissions from a healthcare sector. This particular study didn't necessarily include research and investments, so it may even be a larger impact. So there are certainly many, many areas that we can consider targeting across the healthcare system, whether it's waste, even our landscaping, sterilization, transport, the building infrastructure, but certainly the clinical decisions that we make have incredible importance as well. So in New Jersey, we wanted to think about how could we potentially develop a roadmap within the state to help to guide some of these healthcare transformations that need to happen and need to happen expeditiously. So what we had done, this was within ACP, within the American College of Physicians. ACP is the second largest group of physicians, second to AMA, the American Medical Association, which actually recently passed some resolutions regarding health and climate change, which were very exciting. I am the chair of Health and Public Policy for ACP New Jersey, and we had approached one of our senators, Senator Vitale, who oversees Health and Human Services. And we asked if we could pull together a task force with representatives of the major health systems across the state. We wanted to build consensus and come up with a set of guidelines that would be agreed upon by all the health systems on how we could potentially guide healthcare transformation. So we met about 4 times. We emailed a lot back and forth, and we ended up with a 34-page document that was informed by science, informed by Healthcare Without Harm and Practice Green Health resources, informed by local leaders and scientists, and again that met that goal of building consensus and really had people interested and excited. The name, it actually took me longer to come up with the name than I think the entire 34-page document, Sustainable Initiatives to Guide Healthcare Transformation. And I have the website up at the top. I'll just be going over some of the overarching categories, and certainly I can take questions about any one of these categories in more detail. We had initially started with the Providence model. They use We Act. So it's waste, energy, agriculture, chemicals, and transportation. And we expanded it a little bit. So we wanted to make this as practical as we could for individual health systems. So we built in some of these other areas, including parsing out the OR, just because it does have such a large impact in and of itself. So I'm going to go into a couple of these in a little bit more detail. Oh, sorry. Can you all still see this? Sorry about that. So just a few of the recommendations for leadership, and we put this first because it really is fundamental to get buy-in from the C-suite, to have key physician or other leader champions across the organization that are driving this, and to create green teams that have broad representation, whether it's from dietary or nursing down to EVS or your environmental services, and a director level representation that can really advocate and speak to a lot of the initiatives that you're seeking to drive. And developing things like charters, developing sustainability strategies. So in terms of financing this, we put this next because, again, this is often what it comes down to. It comes down to an ROI, to getting what those return on investments are. And this was some data from the University of Washington that in these studies, it actually suggests that that $800,000 in investments can be equivalent to about $16 million in revenue generating services. And if this sounds like an astronomical difference, we do have some historical precedents for this. That the Clean Air Act has yielded a benefit of about $30 to every $1 invested since its inception. So this actually is feasible. It is possible to see these kind of return on investments, and working with CFOs and working with finances is incredibly important in all of these initiatives. And as was alluded to earlier, we don't know exactly what the Inflation Reduction Act will yield, but certainly there's a lot of excitement from that. In the meantime, we can certainly bring to our leadership things like shared savings agreements, which are third-party agreements where the costs are paid from energy savings, or power purchase agreements, where again you'll have a third party installing and operating a power producing renewable energy source. And carbon offsets are always a possibility as well. In terms of supply chain, as we said, this leads to about 80% overall of emissions. So there's enormous opportunities. Certainly the National Health Service in the UK is already working towards this, and we may benefit somewhat from the global ramifications of them greening, but we have a lot of work to do on our own. Within your own health systems, though, working with supply chain to see what those hidden cost of ownership are, if your purchasers have done life cycle analyses. You can build this into your DEI efforts. So building diversity into your supply chain, into who you are purchasing from, and evaluating expired materials. So at Cooper Medical School of Rowan University, we have a very robust simulation center. So can you use some of those expired products in your simulation training? there's a lot of creative potential uses if you just scrape the surface a little bit. Oh, and certainly I should acknowledge that Practice Green Health has a sustainable procurement guide as well, which is incredibly helpful. Now, waste, health systems spend a lot on waste, on getting it carted away, on red bag waste, particularly that regulated medical waste. So there are opportunities where you can have complete cost savings. It's really just the cost of education of staff and clinicians. You can set a goal to try to achieve a regulated medical waste of below 6% or less than 100 tons per OR per year. This can be measured. This is attainable. You can look at the overall pounds of waste per patient per day. You can set a goal of 20 or maybe 23. Look at what your baseline is. These are numbers that you can definitely acquire from your facilities department and set a lower goal. You can partner with composting facilities. There was some talk in New Jersey about having regulations about partnering with composting facilities. So we're looking forward to future regulation on that. Think about trying to move away from styrofoam. In New Jersey, we've eliminated single-use plastic straws and plastic bags. So certainly that's something that you can do within your individual health system. You can work on recycling batteries and bulbs. We've started a laryngoscope recycling program where all of the components are recycled, partnering with an independent vendor. You can mitigate your water use, and this is within the hospital and without, because you can think about planting indigenous resilient landscaping where you won't have to be using tons of pesticides and water and watering it every day, especially when you're in the midst of a drought. You can use low water use fixtures. You can try to set goals of how many gallons per day per patient, and you can do creative solutions like capturing rainwater and using non-potable water for irrigation, and certainly optimizing alcohol-based hand rubs and educating on that can also have the dual purpose of educating on patient safety and reducing hospital-acquired infections. I have the OR separate just because, as I was saying, it is such a huge energy and waste sink. So in general, the OR is about 30% of the regulated medical waste in a health system, and it contributes anywhere from 40 to 60% of a facility's supply costs. It's very, very supply intensive and energy intensive. Per square foot, the OR is using about 3 to 6 times more energy than the rest of the hospital. So there are a lot of opportunities. Some of them overlap with other areas like energy, but there are some unique opportunities. So maybe your OR can do things like decreasing the number of energy or of air returns, especially when it's not in use. You can do things like managing the temperature. So the temperature is usually kept very cool in the OR for physician and staff comfort. We know that very cold operating rooms have a side effect of contributing to hypothermia in patients, which can contribute to coagulopathies. So again, that's an area where patient safety can actually marry with some of our energy efficiency initiatives. There are very unique type of cooling devices that surgeons can wear, whether it's around their neck or vests, particularly when you have orthopedic surgeons who might be wearing heavy lead. That can get very, very hot. So if you can cool the person and not cool the entire room, again, energy benefits, and it's also better for the patient. You can also look at a lot of the trays. So this might be with preference cards from individual surgeons. This may be from tray optimization committees. This may be in conjunction with a performance improvement department, or it could be department by department. There have been studies done from anywhere from vascular surgery to laparoscopic surgery on decreasing the tools per tray and the cost savings that results from that. And again, there's no cost expenditure there. That's only cost savings that results. Working on reducing OR waste. you can try to switch from the soft trays with polypropylene blue wraps to hard trays. At Cooper, we're in the process of doing that, but we also use our polypropylene blue wraps and we sew them into sleeping bags for the homeless, which we distribute at a soup kitchen. And also, because we've gotten rid of single-use plastic bags, we're sewing them into reusable bags as well and distributing that to the community. And we have a large network. We're up to about 40, 50 people, 40, 50 sewers. These are nurses, these are clinicians, these are people in our business office who all come together and they pick up blue wraps. I have bags and bags of blue wraps in my office and they sew them up. So it's wonderful. And then of course, energy. So there are huge opportunities with energy, and this is something that partnering with leadership is really key on. But certainly doing what you can within your own individual departments, making sure that you're turning off computers, machines. Radiology in particular has a huge opportunity here. They're very energy intensive. Turning off lights, installing motion sensors when possible. Some of the low-hanging fruit that can get conversations started is even just talking to leadership about divesting from fossil fuels and turning to those more environmentally, socially responsible investment sources. So this is something that can be also discussed with societies and organizations. So looking at some of those things you can do first, second, and third, I think will also help to get C-suite and leadership on board with advancing an agenda of sustainability. And then education. So as I've started teaching this to my medical students, my residents, and now to faculty, there's a lot of excitement that comes from this. And because there's such a steep learning curve, I think people really want to, I think they're really hungry for this knowledge. And at medical students in particular, I know at CMSRU, this is going to be a cornerstone of our education moving forward, and will really be integrated at every level throughout the education, because we have to be mindful about equipping our students to become physicians in the future that will have to understand and recognize this more and more and educate our communities on it. It can certainly be incorporated into sustainable QI as well, doing metrics like carbon footprinting. These are all things that can be incorporated into QI, both for research purposes and also as part of the QI agenda. I know in internal medicine, it's a requirement for us that all of our residents are doing QI. So this is something that we're doing anyway. So doing it with a mind with an eye towards sustainability can just broaden that experience. And then agriculture, we had already alluded to the cost of beef to healthcare's greenhouse gas emissions, but certainly there's a lot of creative ways that you can do this, partnering with local farmers to a farm to table initiative. We have a farmers market in our lobby during the summer. So having your healthcare facility sign on to the Cool Food Pledge is also a wonderful option. It really helps you to minimize your greenhouse gas emissions and also create a healthy food environment, and certainly educating your patients. I know a lot of our patients who are in environmental justice communities have multiple overlapping comorbidities, whether it's cardiovascular, diabetic, metabolic syndrome. So educating them on all of these health co-benefits is enormously important. And in terms of chemicals, we've been working to switch our chemicals to green cleaning products. And this is even important for the engagement of our environmental staff. So our cleaning crews that come in, they want to know that the health system cares about them and are aligning their health issues with green and safe cleaning products. When you're doing new construction, you always want to think about mitigating the use of any type of harmful chemicals and moving away from things like triclosan and triclocarbane. Again, some of these are very easy shifts that you can do within an organization. And then construction. So a lot of healthcare systems are talking about construction, and we need to be thinking about designing our buildings for the next 50, 70 years. So these buildings are going to be around for a long time. And so we need to have an eye to the future. And in New Jersey, of our 2,270 or so LEED certified buildings, only 3 right now hold full healthcare certificates. And that will hopefully be increasing very soon. But certainly there's a lot of opportunities, and there's also some wonderful organizations that we can partner with, such as ASHRAE and others. But certainly with an eye towards LEED buildings, whether silver, gold, maybe platinum, very important. And additionally, as you're considering, I'm just going to go ahead for 1 second. As you're thinking about new construction, you also want to think about healthcare resilience, and that's important for infrastructure. We've seen what's happened with healthcare systems. Like in New York, they were building retaining walls to be about, I think it was like 13 feet or something, but storm surges went 14 feet. So all of these major health systems like NYU Langone ended up flooding. So having a really well-informed resiliency plan is incredibly important. I'll come back to that in a second. So transportation. And this can be anything from trying to incentivize virtual meeting participation, maybe not traveling as much to national conferences, to promoting telemedicine, which I think, a lot of us had to fast track during the pandemic, but keeping those options open for patients both improves patient access, but has the dual benefit of decreasing our greenhouse gas emissions, and also looking into alternative fuel fleets, whether it's for our ambulance system, whether it's for shuttles. We have a lot of opportunities in terms of our transportation, and trying to incentivize carpooling when people are coming in. Additionally, with resilience, there are some other great resources out there. CDC has the BRACE framework, which is a 5-step process that allows health officials to develop strategies and programs that will help communities prepare for effects of climate change. There are additional services out there that can also be very, very helpful. So you want to think about, when you're designing resiliency, not just the hospital operations, but also ambulatory care. You want to think about access to pharmaceuticals. How are the ambulances going to be able to get through? And then you have to think about the infrastructure vulnerability. If there are power outages, what are backup power sources, as well as other continuity considerations. And Cooper, certainly being in Camden, is a healthcare and community anchor. And so people really look to healthcare to guide them through these natural disasters that we'll see happen more and more. So leading into, again, this climate resilient healthcare, we want to think about sustainable design, renewable energy, minimizing our waste, sustainable transport, low carbon procurement, and our resiliency strategies. And a report from Healthcare Without Harm with the World Bank really lays out some data-driven strategies to reduce our carbon footprint. The U.S. Climate Resilience Toolkit is also very helpful. I would encourage people to look through this resource, again, especially as you're working with your individual health systems. This is from Practice Green Health, just showing an example of some of the return on investment, again, because those financial considerations are often rising to the top, and it's often one of the entree points to further discussions. And so showing that return on investment that other health systems have benefited from can be extremely helpful. Now, overall, if U.S. health systems did start to adopt best practices, there would be enormous healthcare savings. And so I think that's what we all want to see. This is money that could be used to better our care for our patients, can go into research, can be put to much better use. So some of this is adopted from Dr. Sack, some of the benefits of going green. I chair engagement, so I'm very interested in physician engagement, and I can certainly say that from a wellness and engagement standpoint, people get excited with this work. It improves morale when you have the added benefit of lowering costs, of improving public relations, and just from a pure marketing perspective, patients want to see this as well. And it helps to guide our community, since we are beacons of health to our community. So I'll just close by putting in perspective that all of the healthcare training that I had through medical school, through residency, really only impacts about 20% of a patient's health. So I think more and more physicians need to be engaged in public health, in wider discussions, and be advocating for change within our health system and within our state. I'll just add that now with our ACP initiative, we're working with additional state senators, and we're drafting this into legislation, which will be presented when everyone reconvenes in the fall. And we're very excited to hopefully have a bill to show for this, and really get all of our healthcare systems on board with first steps towards sustainability across the state. So I'll turn that back over to you, Alan.
Well, thank you. That's great, and you covered an awful lot in a short period of time. So I'll make a couple of comments I thought about, and see if there's any while you're speaking, and see if there's any questions, and then I think we'll be able to be on schedule to start the next panel. One is, I'd like to thank a couple of people who I know are with us this morning. One is Amy Collins, who's a physician in Boston and a physician leader for Healthcare Without Harm. She's been putting some helpful information in the chat about other resources. So thank you, Amy, and all the folks at Healthcare Without Harm. Two is, I see that one of our members of county council in Newcastle County, Delaware, which is northern Delaware, Dee Durham, is on with us. And Dee, I know Dee is a leader in the plastics-free Delaware movement, and it sounds like there may be a potential opportunity to learn a little bit about what healthcare is doing, for example, at Cooper, and what we can do here in Delaware to aid that movement to plastics-free. There's many benefits to decreasing our plastic use. One is plastics are made from hydrocarbons, from basically burning fossil fuels, and two is they're pretty much forever substances, and they go into all sorts of things, human and animal tissue, as we've heard about. So there's a couple of things. I also want to emphasize the idea of a green team. This is something which is many healthcare systems are doing now, and it sounds as though Christiana Care and hopefully our friends at Bay Health and Nemours and St. Francis are also, and Trinity Mid-Atlantic are also thinking about. So this is getting people together who are passionate and starting small, and then building up from there to generate ideas and enthusiasm and bring other people on board. There's a concept called the virtuous cycle. And many times when we talk about climate change, people say, it's really important, but I can't do anything about it. It's somebody else's problem. And I think what we see, the concept of virtuous cycle, is doing even small things gets people excited and interested and energized. And I think Lisa was touching on this, to do more things. So a little thing such as recycling a plastic bag into something which is useful to homeless or to be reused in some way gets people started. So I think no action is too small. So that's another quick comment. And I guess maybe the last one I'll mention is, if you're not aware, actually two comments. One is, if you're not aware of the White House Climate Pledge, take a look at it. Many of the leading healthcare institutions in the country, including pharmaceutical companies, device makers, manufacturers, and health systems, have signed on to the White House Climate Pledge. One part of the pledge is to have a senior level executive in your institution be responsible for environmental and climate change and pollution topics and issues and initiatives. Don't assume that if it's just part of somebody else's job, a small part and not measured and not focused upon is going to happen. Another part of that pledge is a 50% reduction in carbon emissions by 2030. So many organizations throughout the country have signed on. I'm not sure if anybody from Delaware has, but it would be really great. And maybe the last comment before we take a break. I know I snuck in a break a little earlier, and I guess Stacia's gotten information about the White House climate pledge in the chat. Is that here in Delaware, in Sussex County, there is an initiative of a partnership between community organizations and healthcare systems. I think specifically BB and Nanticoke, working with Habitat for Humanity and with Energize Delaware, which is one of our sponsors, as well as with the Blue Cross Blue Shield, Highmark Blue Cross Blue Shield, which has put up some money for this to do energy retrofits in housing in Sussex County, housing which is in which folks with asthma, for example, or chronic lung disease live, knowing that the indoor air environment is hazardous to the health of the 10 to 15%, 20% of kids in Delaware who have asthma. So there are things that we can do that sound really small, but working with our partners in other states and within our own state will and has been shown to magnify our impact.